and I've been asked to talk about the diagnosis and evaluation of pulmonary hypertension. And so many people in this audience would be familiar with the definition of pulmonary hypertension, that being a mean pulmonary artery pressure of greater than 25 millimetres of mercury. But hopefully by the end of the presentation, you'll join me in the understanding that this is quite a simplistic definition of pulmonary hypertension, and I think in isolation is really insufficient to diagnose the nature of pulmonary hypertension as well as to guide therapy. And that is because pulmonary hypertension, I think, is becoming more complex. And I think that's illustrated in this slide that outlines the various causes of pulmonary hypertension. Now, certainly the vast majority of pulmonary hypertension is related to left heart disease or underlying pulmonary disease. And that's something that I'll expand on during the course of the presentation. But I would like to spend some time focusing on pulmonary arterial hypertension, or if you like, idiopathic pulmonary arterial hypertension. And the reason for that is because there's been an increasing focus on this disease. In the past, this has had a terrible prognosis, and looking back historically, the outcomes for this disease were really very poor. But this has changed over the last 10 or 15 years with newer agents, such that we are now at a stage where we actually have studies that have clinically driven outcomes, as opposed to the initial studies which really looked at things like 6-minute walk test and invasive hemodynamics. There's been an evolution in the available agents. Going back 20 years, all we had were continuous intravenous prostacyclins, whereas now we're entering an era of oral therapy, either as monotherapy or in combination. And we've certainly realised that treating patients earlier in the disease process improves their outcome. And so this has led to an area of screening as well as an understanding of genetics. Now, when it comes to diagnosing and evaluating pulmonary hypertension, I think the key issue is differentiating between pulmonary arterial hypertension and pulmonary hypertension secondary to other causes. We know that pulmonary arterial hypertension is a disorder of the pulmonary vasculature characterised by elevated pulmonary vascular resistance, for which there are specific therapies that we'll talk about as the evening wears on. Secondary pulmonary hypertension is much more common, and again, that's something I'll talk about in subsequent slides. But I think because there are so many alternate causes, that is the difficulty in assessing these patients with pulmonary hypertension. Its importance in terms of differentiating cannot be understated. Firstly, to ensure patients get appropriate treatment, but secondly, because we know of the adverse effects of the specific pulmonary hypertension drugs. When inappropriately used, they can worsen patients' breathlessness, certainly in patients that have underlying pulmonary disease. We know that endothelin receptor antagonists can cause fluid retention, which is problematic in patients with left heart disease. And we also put our patient at risk of the liver function test abnormalities seen with endothelin receptor antagonists. Furthermore, in Australia, this is important because we have restricted availabilities of these therapies. These agents are only prescribed through specific centres after a central application process. Patients need to meet a specific hemodynamic set of criteria and demonstrate ongoing improvement in order to get ongoing provision of the therapy. Going back to that earlier slide, I think classifying pulmonary hypertension into different numbers is very difficult. And that is because there is often an overlap in a number of varying contributors to pulmonary hypertension. I think our basic diagnostic tools lack precision in terms of differentiating these causes, which hopefully I'll impress upon you this evening. But certainly the biggest difficulty is that certain conditions can coexist. Now, Dr. Bastian will try and convince you otherwise, but I think that echocardiography overestimates pulmonary pressure from time to time and is limited in terms of assessment of diastolic function. Lung function testing is certainly important, but again, a low diffusing capacity, one of the criteria we use to consider pulmonary arterial hypertension, lacks the sensitivity and specificity to be a diagnostic test in its own right. We've tried to overcome this at the John Hunter Hospital in Newcastle, where Barthia had worked, with a dedicated pulmonary hypertension clinic. And as I said, this is in part because these agents can only be prescribed through designated centres, but certainly because we value the input of our colleagues. we're very fortunate to have, in fact, representatives from respiratory, cardiology, rheumatology and immunology, all of whom contribute in terms of defining the various contributors to pulmonary hypertension. And I think certainly in my experience has emphasised the importance of having supportive subspecialties when dealing with these patients. Now, this is an algorithm designed to outline, if you like, the investigation of breathlessness more broadly, but pulmonary hypertension more specifically. And I will talk about a number of the investigations in detail. But the things I do want to emphasise is, one, the importance of the right heart catheter in assessment of these patients. I don't think echocardiography alone is sufficient, but Dr. Bastian will talk about the nuances that perhaps escape an interventionist like myself. Now, to expand on that hemodynamic definition that we mentioned in the first slide, mean pulmonary artery pressure greater than 25 millimetres of mercury. Now, in the past, we included an exercise component, a mean pulmonary pressure of more than 30 millimetres of mercury with exercise. This is controversial, and again, my colleague Dr. Bastian will talk about the role of exercise in assessment of these patients. I think it's very important when talking about pulmonary arterial hypertension that we exclude left heart disease by having a normal pulmonary capillary wedge pressure of less than 15 millimetres of mercury, as well as an elevated pulmonary vascular resistance of more than 3 Wood units. And that really highlights the importance of the right heart catheter, because we need an assessment of cardiac output in order to accurately assess pulmonary vascular resistance. Furthermore, the right heart catheter can confirm the presence of left heart disease with an elevated wedge pressure. We can exclude left to right shunt by assessing the pulmonary artery saturation. And in cases where there is a significant intracardiac shunt as a cause for pulmonary hypertension, by assessing the pulmonary vascular resistance, we can see whether this is potentially reversible with defect closure. Furthermore, the right heart catheterisation gives important prognostic information, and that's something that I'll elaborate on. Now, certainly, as I've mentioned, left heart disease is the most common cause of pulmonary hypertension. And when we looked at the echocardiograms done at our institution between 2005 and 2012, we found that in patients with pulmonary hypertension, more than 70% could be primarily attributed to left heart disease. And that's certainly supported in the literature. The other reason I think left heart disease is really important is because it almost certainly coexists in our elderly patients who do have pulmonary arterial hypertension. They almost all have a predictable component of diastolic dysfunction. And that raises this issue, as I mentioned before, of coexisting disease processes. We know that having coexisting left heart disease not only affects one's response to treatment in terms of their exercise capacity, but certainly limits some of the medications that we can use. And in particular, endothelin receptor antagonists are prone to a degree of fluid retention, which can limit the use of these agents in left heart disease. So a couple of comments now about right heart catheterisation. As I mentioned, looking at mean pulmonary pressure alone is relatively simplistic. And again, having a pulmonary capillary wedge pressure as a cutoff is somewhat simplistic as well, as it implies there's only one disease entity. But as I said, pulmonary arterial hypertension can certainly coexist with left heart disease. And certainly looking at the difference between the diastolic pulmonary artery pressure and the pulmonary capillary wedge pressure can help differentiate between pulmonary hypertension purely due to left heart disease or where pulmonary arterial hypertension coexists with left heart disease. In terms of additional diagnostic testing, I think formal lung function testing is invaluable. Certainly in investigating unexplained dyspnea, but the isolated reduction in diffusing capacity is certainly a guide that perhaps we should think about pulmonary arterial hypertension as a cause. And it's worth noting that this is not information we get from our bedside spirometry. In terms of differentiating whether pulmonary hypertension is related to lung disease or intrinsic pulmonary vascular disease, certainly having an FEV1 greater than 60% of predicted or an FVC greater than 70% of predicted is certainly a guide that there is unlikely to be a significant pulmonary component. High-resolution CT imaging, however, is extremely useful in differentiating between underlying intrinsic pulmonary disease and pulmonary arterial hypertension. Just in terms of some additional components, we use the 6-minute walk test very frequently, and whilst this is not a specific test by any means, it does provide important information in terms of prognosis. In Australia, it's actually essential in terms of provision of ongoing medical therapy. Patients have to have a 6-minute walk test and an echocardiogram every 6 months, which needs to demonstrate either improvement or at least lack of deterioration. The only problem with this test is, aside from the fact it's very straightforward, is that there's almost certainly a component of exercise training. And so patients will actually improve simply by doing the test. And it's interesting that when you look at the original studies of pulmonary hypertension drugs, the improvement in 6-minute walk distance was in the order of 40 to 60 metres. Cardiopulmonary rehabilitation can improve the 6-minute walk distance by 80 metres. And so it just goes to show that role that exercise training can play in looking at a test like a 6-minute walk test. In terms of further investigation, as mentioned on one of those earlier slides, chronic thromboembolic pulmonary hypertension is one of the possible differential diagnoses. Certainly CT pulmonary angiography is excellent at looking for acute pulmonary emboli and excluding additional pulmonary disease, but can occasionally miss chronic thromboembolic pulmonary hypertension. And I think ventilation and perfusion scanning is really important when you consider that diagnosis. In Australia, we have an obesity problem. We have many people who are overweight, and along with that is an increased incidence of sleep-disordered breathing. And in Australia now, assessment for obstructive sleep apnea has become a routine component of our assessment in patients with pulmonary hypertension. My respiratory colleagues don't believe that in isolation, sleep-disordered breathing can cause severe pulmonary hypertension, but is a very common coexisting aggravating factor that we find in our practice. Now, having done all of these investigations and having made a diagnosis of pulmonary arterial hypertension, we can turn our attention to prognosis. Intuitively, patients will have a better prognosis if they're picked up early in the disease process with an improved functional class, whether that be WHO class 1 or 2. We know that preserved right ventricular function is important, whether that be by echocardiography or MR imaging. Of note, the presence of a pericardial infusion is a poor prognostic factor. We know certain hemodynamics imply a poor prognosis, not only the right atrial pressure, but also the cardiac index. And again, that requires assessment of cardiac output, hence the importance of the right heart catheter. Again, patients with a superior functional class will clearly do better on a 6-minute walk test, which in turn reflects their prognosis, as well as their performance on more sophisticated cardiopulmonary exercise stress testing. I must say we don't do assessment of VO2 max as a routine, and really in Australia, this is limited to patients being considered for heart-lung transplantation. Similarly, we don't use BNP routinely, but again, an abnormal BNP goes along with a poor prognosis. So intuitively, it makes sense that prognosis is influenced by your baseline functional class. And often patients are quite limited by the time we make the diagnosis. And so the goal should be to identify the disease early in the process. There's some registry data from some of my Australian colleagues in Western Australia that looked at time to diagnosis for patients with pulmonary hypertension. And even amongst physicians who have an interest in pulmonary arterial hypertension, there was quite a dramatic delay in diagnosis. There were a number of consultations, a number of different specialties, a number of different investigations. And that time from symptom onset to diagnosis was quite prolonged. And so certainly amongst the Pulmonary Hypertension Society in Australia, there's an emphasis on improving awareness with dedicated clinics, but also screening high-risk populations. This slide hopes to further impress that need for early diagnosis. We know that patients can have a long lag time of asymptomatic disease whereby the cardiac output is preserved, but the pulmonary arterial pressure and the pulmonary vascular resistance gradually increases. There comes a time where patients become symptomatic of their pulmonary hypertension, And at that stage, their cardiac output starts to decline. And as I mentioned, that certainly influences prognosis. And then as the disease progresses, the pulmonary artery pressure, as measured by echocardiography, decreases, as right ventricular function decreases, and cardiac output decreases. And so as you can see, hopefully this slide illustrates the importance of early diagnosis. In terms of screening, we look at high-risk populations, and I think the best studied and most common population are those patients with autoimmune disease, and in particular those patients with systemic sclerosis and its variants. Now, whilst the guidelines suggest assessment including things like telangiectasia and certain antibodies, that's designed to pick out the highest risk group, and that's the patients who have CREST syndrome. Certainly in our institution, all patients with scleroderma or any of their variants will undergo routine echocardiography with exercise, and again that's something Dr. Bastian will elaborate on, with an increasing low threshold to proceed to right heart catheterisation. Now, one of my colleagues in Newcastle has a particular interest in autoimmune disease and pulmonary arterial hypertension, and so he's expanded this to looking at patients with SLE, but in more recent times looking at patients with rheumatoid arthritis. And certainly when using a combination of exercise stress testing and echocardiography, there is a not insignificant proportion of patients with rheumatoid arthritis who also have pulmonary hypertension. So I guess to summarise, because we have some excellent cases to discuss, I think the diagnosis of pulmonary hypertension is complex and can't simply be defined as a mean pulmonary artery pressure more than 25 millimetres of mercury. There are multiple contributors to pulmonary hypertension. And I think it's important to have various specialists involved who may be able to help tease out the various contributors. I think having a structured approach to dyspnea is important to avoid that delay in diagnosis that I mentioned. Certainly our experience at the John Hunter in Newcastle has benefited from a team approach involving various subspecialties. I can't overemphasise the importance of right heart catheterisation, not only to confirm the diagnosis, exclude shunt, but also assess cardiac output and therefore provide additional prognostic information. And I think there really is an important role for screening, particularly in those patients who are at high risk. And with that, thank you for your attention.